Welcome to Kids Doc Now with Dr. Jennie. Today's guest is Dr. Innessa Donskoy talking about sleep. Dr. Donskoy is a pediatric sleep medicine physician at Advocate Children's Hospital in Illinois. She is also a clinical assistant professor at the University of Illinois at Chicago College of Medicine. She completed her pediatric residency at the University of Illinois at Chicago and her sleep medicine fellowship at Northwestern University and Lurie Children's Hospital.
Welcome to Kids Doc Talk with Dr. Jennie. Dr. Jennie is a board-certified pediatrician and is the Director of Telemedicine at Pediatric Associates.
Hi, Dr. Donskoy. Thank you so much for joining me today.
Thanks, Dr. Berkovich. How are you?
I'm great. I'm excited to talk about sleep because I have spent a lot of time talking about this with you. And so I felt like it really warranted a whole episode. So as a general pediatrician and as a parent, why is this even important for me to talk about? Why is it important for us to discuss sleep?
Yeah. I mean, this is a question that has an answer in science and in research and in evidence, but the answer I think primarily comes with what we see day to day. We intuitively can look at our child, see their behavior, see how they're interacting with us, with their peers, with their siblings, and get a feel. And I'll often hear a parent even say, gosh, I think my kid is overtired today, or, oh man, I'm so sorry, he really skipped his nap today, right? We understand what sleepiness looks like. And the data really supports it. Physiologically, there's a lot of changes that happen when we are sleep deprived or get an insufficient amount of sleep. Our cortisol levels are up, our stress levels are up. We know that long term, when we look at adults who are sleep deprived over long periods of time, we have increased morbidity and mortality. So there are very real physical changes that happen when sleep is poor or insufficient, but we know that psychologically also it takes a real toll. And with sleep deprivation, we see increased incidences of anxiety, depression, and even before we get to those diagnoses, what we know based on beautiful fMRI imaging studies and a lot of paper that has come out looking at acutely sleep deprived, even adolescents, is we sort of lose this connection between our emotions and the ability to kind of use our prefrontal cortex, pause, stop, process, and really think critically, even on a subconscious level of, is it appropriate to act on this emotion right now? And so we have this big mood lability that comes with insufficient or poor sleep. And that's what we see playing out, right? Really reactive, externalizing behaviors, and sometimes internalizing behaviors too, right? Those low moods, those anxious feelings, they're harder to control and process when we get poor sleep. So across the board, right? Physically and psychologically, it's really important to get it. And that's why we're talking about it.
So that's really fascinating. Actually, I think we'll probably get into some of that a little bit later on. But the burning question that I always get is, how much sleep should kids be getting? Because I think parents feel like this intense pressure of getting to and sticking to a bedtime and getting the kids up in the morning. But then on the weekends, can we let them sleep in? And is that okay? And this obsession, I think almost like an obsession that parents have with bedtime. So walk me through this a little bit of what we expect kids to be getting at different stages in life in terms of sleep length.
Yes, this is the hot button question. It's both my favorite and least favorite answer to give. So there is this immense pressure, and I'm so glad you described it. You described it so beautifully. We're getting pressured. I'm a parent myself. We're getting pressured from every area to have everything be so perfect for our children, their nutrition, their extracurriculars, and their sleep, is one of them, for all the reasons that we just talked about it being important. And so people put a lot of pressure on this and a lot of stress on this, and they really try to get their kids to have good sleep. But the ironic thing about that is it's a little bit like holding sand in your hand, right? The harder you hold, the more likely it is that it's not going to go well. Sleep is one of those things that, interestingly enough, you got to be really relaxed about, right? You have to be really calm and wound down and relaxed to even fall asleep yourself, let alone do bedtime for a little cutie pie that's going to feed back from everything you're feeling in that moment. You're feeling stressed that your kid needs to go to sleep, because you care about, how they're doing, but also because you need to get things done as a parent. They're going to feel that energy, and bedtime is going to now become immensely more challenging because of it. So I think the first place to come at this is reflecting on those emotions in yourself, right? And of course, it is important for our kids to have really great quality and a really appropriate quantity of sleep, but that can't be at the expense of really getting them less because we're going about it in a stressful way. If we talking about like numbers, there are a lot of different sources. So the National Sleep Foundation has a nice broken down table of ages from infant to adolescence of how many hours of sleep they recommend. The American Academy of Sleep Medicine has one as well. It doesn't touch on infant sleep because if you've ever looked at you have, you're a pediatrician. If a poor parent has ever looked at the ranges of sleep hours recommended for an infant, it's like basically 0 to 24, right? So they avoid that because it is such a wide range, but they give good values too. And very recently, just last month, the American Heart Association also came out with some nice data tables of recommended ages and quantities of sleep, which is nice because that particular one actually is backed with some research looking at how children do function, especially psychologically, especially in the school learning environment, on certain hours of sleep. And that's really nice because all of the other, not all of the other data, but a lot of the other data is really survey median data, which doesn't serve us so well because it's not necessarily saying this is an optimal amount. It's saying this is the average amount people get, right? And your child should fall somewhere in here. So those ranges are nice starting points. But again, really the most appropriate amount of sleep for your child is a quantity and a time frame where you're finding that your child's falling asleep easily, staying asleep, waking up on their own, feeling refreshed, and able to get through their day and accomplish all of the things they need to. If all of those things are happening, then the amount of sleep that your child needs is the amount that they're currently getting.
So I think that's really critical for parents to hear because I find that people want to fixate on the numbers, and then that adds extra stress to like, well, then if I have to get them right back up for 7, right? Because the bus comes at whatever, 7:45, that means working backwards. This is what time I have to get them to go to sleep. And why aren't they going to sleep? And oh my goodness, that means I need to give medicine. I'm doing something wrong. And now we're all stressed. And sounds like that's exactly the opposite of what we should be doing. So I'm very reassured hearing this, but I also see a lot of parents who struggle with a consistent bedtime, not because anything has gone wrong, but what they report is like they just won't go to sleep, right? And they tell me about kids who it's 10 o'clock at night and it's, she's a 6-year-old just wandering around the house and she's just not sleepy. And they've done all the things. They've done the bath time and the quiet time and the bedtime and picking out the story and the second story. And like this kid isn't going to sleep and the parents are desperate. You probably see a lot more of this than I do. What's like a good approach for families to start addressing this type of situation?
Yes, this is my everyday patient. I have several of these patients that I'm seeing later today. So it's going to be very individualized, but in some ways systematic, right? So the first thing that you really want to understand about what's going on in this home is just sort of a start to finish all encompassing routine. Right? What parents often want to come and tell me is what they're doing at bedtime, right? The bath, the book, the bottle, the book, the second book. And then we're sort of done. But I want to hear more, right? I want to hear about, okay, well, once they're in bed, when do they actually fall asleep? Are they staying asleep? If they're not staying asleep, when do they wake up and how long are they up for, right? Because now that's detracted from how much sleep they've gotten. When are they waking up? Is that the same on a weekend versus a weekday? what are they doing throughout their day, right? Because don't forget, to sleep well, right, to have a really good night, you kind of need a good day of building a lot of sleep pressure, a lot of physical activity, a lot of sunlight, a lot of output, right? So I want to hear about what their day looks like. And then I want to hear about if they're napping throughout the day, right? Because don't forget, we only need a certain amount, talking about the quantity of sleep, we only need a certain amount of sleep within a 24-hour period. If you're paying off your sleep pressure at some point there in the day, that's less sleep that you're going to have at night as well, right? And the timing of that nap is pretty important too, even in the child that perhaps should still be napping for their age. So I want to hear about how that day goes, and I want to hear about the wind down period, not just starting at bedtime, but starting at dinner, right? And starting out what they're doing at dinner, because this will start to really inform me, right, about what's happening in the home. And every day is different, right? Every day is different. So I don't just want to hear about what happened yesterday. I kind of want to hear about what's been happening, usually over a course of about 2 weeks. About 2 weeks can give me an idea of what are the patterns that sort of continue to arise. And parents don't have to come in to see me or anybody. They can sort of just track this on their own, right? There's some nice sleep logs out there. The AASM has a nice one on their website, but you can just sort of jot this on yourself. Sometimes it's eye-opening for the parents to start recording and realizing when certain things are happening when, because what the log will help them do and me do is sort of differentiate between, well, a number of different things, right? One, and the easiest one is perhaps their days are sort of sedentary, and perhaps they are napping in the daytime at an age which they shouldn't be, right? Those are sort of the easiest fixes. Push sleep into the night, right? We don't have a sleep disorder here. We just have a little bit of, broken sleep irregularity, however you want to describe it. And we can kind of push our sleep pressure to make the nights go better. But you may also try to start to differentiate between what we call insomnia, right? Really this difficulty initiating and or maintaining sleep, versus what's much more common, which is a later circadian rhythm, a delayed sleep-wake phase, right? That's sort of the idea of, we all have a quantity of sleep we want, but we also have a window in which we want that sleep. And that's controlled really, really tightly by a part of our brain called our suprachiasmatic nucleus. It's essentially our internal clock that runs whether we like it or not, with pretty close rigidity. And it tells every part of our body when we are most likely to fall asleep, wake up, and a lot of other hormonal processes are run by it as well, our cortisol, our growth hormone. So we're sort of under that control as well. And the log, especially a log that includes several weekends, where likely there are less sort of things to do or things to wake up for, a log that sort of reveals that, okay, we may be falling asleep later, but gosh, we're kind of sleeping in later as well on free days, right? That tells me that this is a kiddo with a little bit of a later time zone, later internal time zone. And we can change that, right? We flip our time zones around twice a year when we have daylight savings, if it sticks around. We change it when we travel, right? So we have to know where we're starting and adjust from there. And largely that comes from shifting day off wake up times to kind of align them with the rest of the week. But you may see that, this isn't a child that's sleeping in at all. In fact, this is a child that truly is having a difficulty starting to fall asleep, and maybe even staying asleep as well. And then we do a little bit more digging and figuring it out, right? What does the sort of entire wind down routine look like? How much light exposure? How much activity is there? What are the things that are on this child's mind? This is a conversation you can have from a very, very early age, believe it or not. I think sometimes I've asked a parent, like, well, what are they thinking about at this time, right? What are they doing at this time? Because the kid's usually playing at this moment. And they're like, I don't know, I haven't asked. So ask your 2-year-old, ask your 3-year-old, what are you thinking about? What are you kind of dreaming about, right? What are you imagining? Are you feeling physically uncomfortable at all, right? Because sometimes, especially in the toddler age, sort of there's this magic diet pickiness that can arrive sometimes, lead to some macronutrient deficiencies. All of a sudden, you got a little bit of a restless picture, right? Which is also a pretty easy fix. Or is this something that's really on their mind, right? We as adults can get stressed, and that can make it difficult to fall asleep, right? And stress is both positive and negative. You can be stressed out because something really tough is happening, or you can have something really exciting coming up. Gosh, and you just want to think about it and imagine it and kind of daydream about it. And that can make it hard to fall asleep too, right? And so talk with your child, talk about what they're thinking, talk about what's going on. Um, and if you're finding or discovering that it is sometimes negative thoughts, right, then um, one of the things that you can start to do is give them a place to put those thoughts. That's maybe not at night, maybe earlier in the day. Maybe you schedule a schmooze time, like a scheduled, like I call it like scheduled worry time, scheduled processing time earlier in the day, right? Because you need a place to put those thoughts. You do. They're not just going to go away because you will them or avoid them. So give them a place to go that's not bedtime. And then as you continue to work on the bedtime prep, right, you want to start to be really mindful about bed timing. And so this is where it is really important to take all your knowledge about how many hours of sleep your child needs and throw them out the window temporarily, hang them out the window with like a rope to bring it back later, right? If your child is having a challenging time falling asleep and you're working on all of these other bedtime wind down, relaxing pieces, what you may want to do is temporarily do what's called bedtime fading, which is just push their bedtime a little bit later. If you've done the logs, then you'll actually know exactly what time to push this to. It's going to be the time that you see, oh gosh, she's actually falling asleep pretty much at like 10:15, let's say, every day, even though we're starting bedtime at 8, right? What you don't want to do is say, oh, it's taking them 2 hours to fall asleep. Let me make bedtime even 2 hours earlier. You actually want to do the opposite. You want to put them in bed a little bit closer to the time that they're really falling asleep now. You're not taking any sleep away from them. What you're actually doing is setting them up for success, right? You're setting them up for success in actually being able to initiate sleep and it taking less time, building their confidence in themselves, your own confidence in their sleep abilities, right? Which may have taken a toll over the past however long this has been going on. And what you're also doing, the most important thing that bedtime fading does, and it's not forever, right? It's for a short time until you kind of build that strength and confidence, is you're building their association between their bed and sleep, right? Their bed needs to be considered by their body almost, subconsciously as a place that, oh, I just get in here and I fall asleep easily. And this just happens every night. And I don't have to do anything, right? I don't have to try. That's what you're trying to build. And sometimes what that means is, yeah, running on a little bit sleep deprived to set them up for success. And then every few days, if, falling asleep is a little easier, maybe inch it a little earlier, right? A few minutes every few days till you get to a spot where they're still falling asleep fairly easily, but in a much more stress-free way and staying asleep and waking up feeling refreshed at that really consistent wake up time. You don't want to create a delayed sleep wake phase. You're doing this all with a pretty set wake up time. But this altogether, this is a part of what we call CBTI, or cognitive behavioral therapy for insomnia. It's a standard of care for adult insomnia. The AASM calls this behavioral techniques in children. And I think a lot of people think that means sleep hygiene, right? Dark
Which is
room,
like, right, doing
cool
all the things, right?
environment,
Yeah.
no screens, right? Which is so important. It is. It's so important. But when you have insomnia, right, sleep hygiene is not really going to help you. Someone out of the VA, interestingly associated with Stanford, once told me that, it's like dental hygiene, right? We brush our teeth, we floss, we do all of these preventative measures to prevent a cavity. But once a cavity happens, you're not just going to be told by your dentist to floss a little more, right? You're going to have a directed, targeted therapy for this issue. And when it's going to resolve, you're going to go back to your dental hygiene. So it's the same with insomnia. We practice sleep hygiene. We practice it every day. But when insomnia sort of rears its head and we need to troubleshoot, then we do some of these maneuvers. We do bedtime fading, right? There's also a partner to bedtime fading called stimulus control. It's a little harder to do in a young kid, but in an adolescent or definitely an adult, it's basically if you wake up in the middle of the night and you can't reinitiate sleep, you can't fall back asleep, you get out of bed. You do something else. You don't stay in bed, because all you're doing by staying in bed is sort of reinforcing the my bed is not for sleep association. It's really hard to do in a little kid, so we generally don't. But all of these sort of facets of CBTI, they really hinge on this idea that sleep just comes naturally, right? That's where we want to get to. That my brain and body associate getting in my bed and my head hitting the pillow with, with fast, easy sleep, where I wake up in the morning and I don't even remember what I had to do to fall asleep.
So I'm imagining you explaining all of this to your patients, and I'm imagining myself using this as a tool for patients. And I have a feeling that what you hear a lot, what I would hear a lot is, that's great. And that sounds like a lot of work and a sleep log for 2 weeks. And then, right. And then telling them to go to
It's
bed
a lot
later.
of work.
Oh my gosh, that's so much work. I bet that I can manipulate the circadian rhythm myself. And I'm going to give them this natural thing called melatonin that I can just get at like Whole Foods. And oh my gosh, it works great. It's like magic. I can't live without it. Parents tell me like it's a lifesaver. It's changed my life. I spent so much time talking about melatonin. Give me like a little bit of a summary of kind of your approach and why it's not necessarily the first thing that you recommend.
Yes, vitamin M. Uh, so, melatonin, for anyone who doesn't know, is it's a neurohormone, right? Our brain makes it about 2 to 5 hours before we fall asleep. And it's in a picogram quantity, in a very small quantity, to get us ready for sleep. It doesn't make us fall asleep. It simply is our body's signal that it's dark, because that's when we make it. We make it in dim light conditions, which is why part of sleep hygiene is, minimizing specifically blue light, because then we'll suppress our own melatonin production. But we make it several hours before falling asleep. It prepares our body for sleep. And by midpoint throughout the night, it pretty much starts to drop off, being fairly low when we wake up in the morning, ready for our day. When we talk about things like delayed sleep-wake phase, or circadian rhythm disorders, or jet lag, or shift work disorder, people are shifting back and forth really rapidly, actually melatonin is indicated for those disorders, because you're exactly right. When we are changing the circadian rhythm disorder, then really appropriately timed low doses of melatonin prior to when our body naturally makes it will shift our rhythm. And you'll hear sleep doctors all the time recommending one-time dose or a few-time dose melatonin for travel, and especially in the treatment of circadian rhythm disorders. I myself recommend it in those cases. What I see or what's really been happening, especially in the United States, where you don't need a prescription for melatonin and it's regulated like a food supplement rather than a medication, is that it's gotten a lot of really actually very impressive PR. Someone should look into who is marketing melatonin, because it's being offered, right, as this like thing that you need for healthy sleep. And that's not totally wrong, because your body is making it, but in very small quantities. And what's interesting is that at really supra therapeutic quantities, so way above that which our body make, talking like 3, 5, 10, 15. I've seen people on 20 milligrams of melatonin. what you see is that it has less of a circadian rhythm shifting effect and much more of a sedating effect. So it is it's a sleep medicine, right? The same way you think about like benzodiazepines, like clonazepam, right? The same way you think about Ambien, right? Those sound scary. They have an indication, right? But that's what this is. This is a sleeping pill. It's a sleeping pill. Are there times that melatonin is used, even though it's not indicated for insomnia? Yes, there are cases, and there is some literature showing it being used in children with autism spectrum disorder. There was actually a really nice study that came out earlier this year that followed kids with autism spectrum disorder out for 2 years on melatonin for insomnia. That's the longest anyone has ever followed a child on melatonin in the literature. And the studies were actually, the findings were actually a little bit reassuring. There were no big shifts seen in pubertal onset, although again, only 2-year follow-up. But that's sort of the big hot button issue is does melatonin delay or sort of speed up puberty onset? That study was reassuring. But in studies where kids with autism spectrum, ADHD, other neurodevelopmental disabilities, there are some studies to show that melatonin can be effective for insomnia. Again, these are cases when we've tried, right? Obviously sleep hygiene, but also directed behavioral interventions, right? And then the decision is being made to start this child on a sleeping pill, the choice being made to, use melatonin first. So, there's not to say that this isn't done or that it isn't even the right choice in some cases. It just has to be made thoughtfully, right? The same way that you're going to think about giving Tylenol or amoxicillin, right? Or methylphenidate or any other medication that you're recommending as a pediatrician or that your pediatrician is going to recommend to you, right? You want to have a discussion. Okay, why are we starting it? Right? How long are we going to be on it for? What dose are we going to take? When in the day are we going to take it? What are we looking for when we take it? And how are we going to know if, we need to stop it?
And
Or is
what are
this
the
going to
side effects, right? And
exactly?
what are the side effects or
effects?
things that we need to worry about? Because it's
Exactly.
even though it is over the counter, right? We've talked about it. Sometimes can lower seizure threshold, right? That's the big one that I know
Absolutely.
about. There's other things that, right, we want to be watching for that may be a sign that this isn't the right medication for us.
Absolutely. I mean, the CDC report that came out again this year, this is the hot issue this year, showed at least 2 deaths from melatonin ingestion, one intentional, one unintentional. But again, you're looking for the side effect, or I guess the goal is sedation, right? So you have to be really cautious.
So I think that's important to hear because, right, so it's not like you're saying no melatonin for anybody ever. You're saying it's a medication that sometimes, right, has an indication and sometimes does not. And what I see that makes me a little bit nervous and that I find really helpful to educate families about is that it's just because you can go get it doesn't mean that you should be getting it and doesn't mean you should be like regulating how much your child is on it, because families that I see, especially certain populations of families who may be on stimulant medication. So those kids we know have an additional challenge, right, of falling asleep and staying asleep. They kind of titrate these doses on their own. So they're on 3 and then 3 didn't work and they took 6 and 6 didn't work. That sounds like these are humongous dosages, right? Or amounts of melatonin that are way over what your body's naturally making. And so we have to do that with caution.
Absolutely, absolutely. And, natural, right? Natural doesn't always mean safe, or better, right? Because there are other sleep, if you're going to think about starting sleep medication, weigh your options. There are other non-natural, but far better studied sleep medications that, if your child has an indication for, are maybe worth discussing with the prescriber.
Okay, that's really helpful. I want to shift gears a little bit and just mention one more topic because as a general pediatrician, I can't talk about sleep without mentioning safe sleep. And
Yes.
so there's new guidelines that recently came out from the AEP addressing safe sleep Talk to me a little bit about that, and what are some of, like, call out some of that maybe major changes, or maybe some things that we can take away for parents to know about safe sleep, especially for newborns.
Yes, absolutely. It was very exciting. Again, a very hot year for sleep. Everyone's talking about it. Honestly, one of the nicest things to see in the guideline was how much didn't change,
Mhm.
right? We had a very clear reinforcement of back to sleep, right? No soft cushioning, no bed sharing, even with these very popular bed sharing devices that
The
are
back of that
absolutely
click in,
everywhere.
right? That's still bed
Yes.
sharing. I just want to make sure that that's clear. The co-sleepers, the ones that click into the bed that have the drop down side, big no for me.
Right. Right. So that was actually very good to see, and really kind of disheartening to see some of the curves of how much improvement in infant mortality there was when these guidelines first came out, and pretty much how much of a plateau there was since then. That was a little bit disheartening to see. But in terms of safe sleep, a lot of those recommendations have stayed the same, and I think it was very important for it to be reinforced when a lot of these devices are coming out, again, being very highly marketed, being very promoted by a lot of very influential people. So I think it's really important to remember back to sleep, nothing in there, nothing soft on their own till a year is still where it's at. One nice change to see, though, was that, while no bed sharing is promoted, there was also this promotion of continued room sharing till a year, which was decreased to 6 months on this guideline, which was also very, very nice because, again, all the pressure that parents get, right? Your child needs to be sleeping through the night by 6 months is a very hot one as well. And when reality is that many 6-month-olds do not sleep through the night. And also, parents need to be really careful about what they define sleeping through the night as, which is a certain amount of consecutive hours, not necessarily, the parental night. But this shift in that really after 6 months, a child doesn't necessarily continue room sharing till a year, which is where the guideline had been, I think does allow for some good opportunities for promoting independent sleep onset, aka sleep training, which is the other thing that we didn't talk about, but a lot of people always ask me about, right? And what do I think about sleep training, or what's the right age to sleep train? And the reality is that sleep training, if you really think about what that phrase means, is just helping your kiddo learn how to sleep, right? That's all sleep training is. And that starts the moment they're born, when you put them down, drowsy, but still a little bit awake. That is sleep training. That's sleep training right there. And so what I think this sort of relaxation in the guideline does allow parents to promote sleep onset, maybe in the child's own space, in an own room now, and helps them kind of learn to foster that independence. So that was a really nice shift to see. I think it reflects what people were sort of doing anyway. But nice to see that it was officially recommended. So now we can officially recommend it. That was one of the biggest shifts, at least from, an insomnia point of view to see, right? Because what happens when we don't promote independent sleep onset is we have a kiddo that does need, right, either the parent or the parental room or a lot of input to fall asleep. And then as the years go by, we might be talking about insomnia and CBTI, right? About how to foster those skills and that confidence in themselves. So an important change that they made.
That's helpful. I think we could probably do a whole nother episode just on sleep training. I've heard you talk a lot about this. I have been very empowered by your view on it. Whenever people ask me about sleep training, I always give them I qualify my answer with here's the doctor answer, and then here's my mommy answer, which unfortunately they just don't fit because I know what to recommend, but having tried to do it myself, I know that I'm personally not very good at it. So I have a lot more questions, but I think this is a good stopping point, at least for part one of this. So I want to thank you so much. This has been so helpful. Thank you so much for taking time and sharing all this amazing sleep knowledge. And congrats on what sounds like a very provocative year in your specialty.
Yeah.
a lot of really exciting things coming up.
My pleasure.
Make sure you like us on Facebook and follow us on Instagram and Twitter. Thank you for joining us on Kids Doc Talk.